Hello everyone. So here we are going to discuss about regulations of ion, volume and water reabsorption in the kidney. At the end of the class, the student should be able to understand role of ions and water absorption in the formation of urine. Outline the regulatory mechanism for reabsorption of ions and water in kidney tubule. Give note on regulation of sodium chloride and water reabsorption and potassium excretion. Describe the mechanism and importance of tubuloglomerular feedback. Appreciate the significance of glomerular-tubular balance. Understand the concept of obligatory and facultative reabsorption of water. List the difference between water and osmotic diuresis. List the diuretics and give their mechanism of action. Understand the mechanism of water balance in the body. Comprehend the regulation of sodium chloride concentration and osmolality of ECF. Appreciate the physiological basis of isoosmotic, hypoosmotic, and hyperosmotic dehydration and volume expansion. List the causes of hypokalemia, hyperkalemia, hyponatremia, and hypernatremia. Coming to regulation of sodium chloride and water reabsorption, as we have understood in the previous class, normally the total sodium filtered is around 12, 26,000 milliequivalents in the glomerulus per day. Almost 99.4% is reabsorbed in the tubule. Of the filtered sodium, about 67% is reabsorbed in the PCT, 25% in loop of Henle, 5% in distal converted tubule, and 3% in collecting duct. Reabsorption of sodium facilitates the absorption of many other solutes and establishes the osmotic gradient for the reabsorption of water. The total urinary sodium output ranges between 1 milliequivalents to 400 milliequivalents, averages about 150 milliequivalents per day, depending on the dietary salt intake of a person. Regulation of sodium chloride and water reabsorption is primarily the function of various hormones acting on the kidney. Neural factors, Starling forces, tubuloglomerular feedback, and glomerular-tubular balance are also play an important role in regulatory mechanisms. So here you can observe almost 67% of the sodium chloride bicarbonates, they are reabsorbed in the proximal conductive tubule. 25% of the sodium chloride is absorbed in the ascending loop of the Henle, 5% in the distal conductive tubule, and 3% in the collecting duct. And almost 150 milliequivalents of sodium is excreted per day. Hormonal factors which are going to affect the sodium uh, regulation. Angiotensin 2 acts mainly on the proximal tubule on the kidney. It increases sodium chloride and water reabsorption and causes expansion of the ECF volume. It is secreted in conditions of hypovolemia and hypotension. Captopril that inhibit angiotensin converting enzyme, that is AC inhibitor, decreases the ECF volume and blood pressure. This prevents formation of angiotensin 1 to angiotensin 2. Therefore, decreased concentration of angiotensin 2 decreases sodium chloride and water reabsorption from PCT and decreases the vasoconstriction. This is used to the treatment of hypertension in conditions of ECF volume expansion. Aldosterone stimulates the reabsorption of sodium chloride and water from the collecting duct. It acts on sodium potassium pump on epithelial sodium channels. It facilitates potassium excretion in the tubular fluid. Thus, it increases the sodium concentration in the plasma and decreases potassium concentration. Among the important regulators of aldosterone secretion are the hyperkalemia and angiotensin 2. Okay. ADH is important hormone for the volume homeostasis. It is secreted from the posterior pituitary in response to hyperosmolality of the plasma and hypovolemia. It increases the permeability of the collecting duct to water by incorporating water channels, that is aquaporins. Glucocorticoids have a mild mineralocorticoid aldosterone-like activity. They increase the water and sodium chloride reabsorption. Urodilatan is a polypeptide hormone containing 32 amino acids secreted by the DCT and collecting duct. It acts on the kidney tubule locally. It acts exclusively on collecting duct to inhibit sodium chloride and water reabsorption from the medullary part of the collecting duct. It is a potent natriuretic and diuretic hormone like that of atrial natriuretic peptide. However, recently the validity of hormone has been questioned. Tubuloglomerular feedback. Signals originating from the renal tubules provide feedback for the control of glomerular filtration, which is called as glomerulotubular feedback. In this process, the rate of flow and the concentration of sodium chloride in the tubular fluid of thick ascending loop of Henle and the initial part of the distal connected tubule provide feedback information to the glomerulus to control rate of filtration. When the rate of flow through the tubule increases, the rate of filtration decreases, and when the rate of tubular flow decreases, the rate of filtration increases in the same nephron. Thus, the change in the glomerular filtration maintains a constancy of tubular fluid, that is, a constant volume of fluid delivered to the tubule. So this is the mechanism of glomerulotubular feedback. So when GFR increases, there is increased filtration, increased load, that there is increased delivery of the sodium to the DCT. There is increased reabsorption of sodium by macula densa cell. There is increased sodium activity. ATP is hydrolyzed. There is increased formation of adenosine, and adenosine acts on the A1 receptors, increase the calcium production and release from the macula densa cell. Okay, so that causes the constriction. Causes the constriction of the afferent arterioles, so that is going to decrease the GFR. Okay, so this is how glomerular tubuloglomerular feedback mechanism operates. Regulation of potassium excretion. Potassium is a primary intracellular cation. Its gradient across cell membrane is mainly determined by the electrical potential across the cell membrane. As excitability of nerves and muscles depends on this electrical potential, precise control of potassium level in the plasma is very, very essential, in which the kidney plays a very important role. Normally, 600 milliequivalents of potassium is filtered in 24 hours, of which 99.3%, that is 500 milliequivalents, is reabsorbed. Minor reabsorption and secretion of potassium also takes place in collecting duct, especially in the intercalated cell. The rate of secretion of potassium by distal tubular cell is proportionate to the rate of flow of fluid through it. If you see the potassium dynamics, 65% of the potassium is reabsorbed in proximal conductor tubule. 25 to 30% is reabsorbed in the thick ascending loop of Henle. 50 milliequivalents is secreted back in the distal connected tubule. Minor secretion reabsorption occurs at the collecting duct. So overall, daily 90 milliequivalents of potassium is excreted per day. Water excretion. Control excretion of urine volume from the body is an important function of kidney. The volume of urine determined by the quantity of water reabsorbed from the renal tubule. Normally, kidney reabsorbs more than 99% of the filtered water. Therefore, uh, through the GFR, though the GFR is about 180 liters per day, 1.1 to 1.5 liters of urine is formed in 24 hours. Even when more than 23 liters of urine is formed per day, as occurs in ADH deficiency, the kidney absorbs about 87% of the filtered water. Okay, so thus the capacity of kidney to reabsorb water is enormous. So this is the mechanism of volume homeostasis in the body. So that means kidney itself is able to reabsorb 87% of the filtered water without the effect of ADH. Types of water reabsorption. It can be obligatory reabsorption or facultative reabsorption. Obligatory reabsorption of water is the water reabsorption that occurs secondary to reabsorption of solids. So this accounts about 85% of the total water reabsorption in tubules, and most part of it occurs in the proximal tubule. Facultative reabsorption of water is the water reabsorption that occurs secondary to the effects of hormone, especially the ADH and aldosterone partly. So this accounts for about 15% of the total water reabsorption from the kidney and occurs mostly in distal parts of the nephron, that is in collecting duct and distal connected tubule. In proximal tubule, almost nearly normally 65% of the filtered water is reabsorbed. The driving force for water reabsorption is the transcellular osmotic gradient, which is established by the absorption of sodium and accompanying solutes. The permeability of the epithelium of proximal tubule to water is extremely high due to the presence of aquaporin 1 in cell membranes in PCT. Water also passes through the water channels present in the paracellular route through the tight junctions between the epithelial cells. Therefore, even the smaller osmotic gradient across the tubular cell results in adequate movement of the water. In the loop of Henle reabsorbs approximately 15% of the filtered water. The ascending limb of loop of Henle is impermeable to water, and water reabsorption occurs mainly in the descending limb. The water reabsorption in descending loop of Henle is passive process that occurs secondary to higher osmolarity in medullary interstitium. In distal connected tubule is relatively impermeable to water. In spite of osmotic gradient across the tubular epithelium, water reabsorption is poor. Only about 5% of the filtered water is removed in DCT, which is influenced by aldosterone and ADH. However, solute is removed actively in excess of solvent in this part of the nephron. The collecting duct has two parts, cortical and medullary. Reabsorption of solute and water from the collecting duct mainly depends on the concentration of ADH acting on it. About 12 to 15% of the water is reabsorbed in collecting duct. In the cortical part, the ADH increases the permeability of the collecting duct to water by inserting aquaporin to water channels. Therefore, in the presence of ADH, water moves out relatively hypotonic tubular fluid into interstitium of the cortex, which accounts for the substantial reabsorption of water in collecting duct in the presence of the hormone. In medullary CD, the water is reabsorbed from the tubular fluid into the hypertonic medullary interstitium along with osmotic gradient, which accounts for the 5 to 10% of water reabsorption. This plays an important role in countercurrent mechanism and makes the urine concentrated. What is diuresis? Is nothing but the excess excretion of water in the urine. Physiologically, it occurs due to the failure of mechanisms that concentrate urine. In diseases, it occurs either due to absence of ADH that results in water diuresis or excretion of osmotically active solutes that leads to osmotic diuresis. Diuresis can be classified into two categories, water diuresis or osmotic diuresis. Water diuresis is excretion of large volume of water without loss of excess of solute. This occurs when capacity of kidney tubule to reabsorb water is impaired. The level of ADH determines the amount of water to be reabsorbed from the kidney. Therefore, ADH deficiency results in water diuresis. For example, in diabetes insipidus, urine is dilute and more in volume. Water diuresis can be physiologically demonstrated by drinking large amount of hypotonic fluid like water, in which the polyuria occurs in 15 to 40 minutes of water ingestion. Osmotic diuresis is because of increased concentration of osmotically active particles in the tubular fluid. Okay, so that increases the excretion of the water. Okay, so this is called as osmotic diuresis. This is typically seen in diabetes mellitus, in which increased filtration of glucose, increased tubular load that causes glycosuria, So this causes osmotic diuresis. By osmotic effect, solutes hold water in the tubules, which prevents reabsorption of the water, and that causes diuresis. Osmotic diuresis is also produced by administration of the mannitol. Osmotic diuresis can also be produced by infusion of large amount of sodium chloride or urea. Diuretics are the substances that promote diuresis, that they causes increased excretion of water in urine. In medical practice, diuretics are usually used to decrease the ECF volume and blood pressure. Loop diuretics, one of the example is furosemide and ithacrinic acid. They are the loop diuretics. They act by inhibiting sodium potassium 2 chloride transporter at the thick ascending limb of the loop of Henle. This inhibits the sodium chloride potassium reabsorption, causing diuresis with the loss of these electrolytes. Aldosterone antagonists. Spironolactone is the commonly administered aldosterone antagonist. It inhibits the action of aldosterone on the kidney tubule by inhibiting sodium potassium exchange that leads to natriuresis and diuresis with retention of potassium in the body. Hence, it is called as potassium sparing diuretic. Amiloride and trimetrin, other potassium sparing diuretics, compete with the sodium for the site in the epithelial sodium channel and block sodium reabsorption and potassium secretion. They produce diuresis with retention of potassium. Thiazide diuretics usually administered uh, as a chlorothiazide. It inhibits sodium chloride co-transporter in the early part of the distal tubule. Thus, increased excretion of sodium chloride produces diuresis. Carbonic anhydrous usually administered as a acetazolamide, commercially Diamox. As the name suggests, it inhibits carbonic anhydrous activity in the renal tubular cells. Xanthines such as caffeine, theophylline acts as a diuretics. They inhibit tubular reabsorption of sodium. They also increases the GFR. Administration of large quantities of osmotically active substances like mannitol and glucose produces osmotic diuresis by increasing their concentration in the tubular fluid. Ethyl alcohol produces diuresis by inhibiting ADH secretion. Acidifying salts like calcium, ammonium chloride acts as a diuretic by increasing the tubular acid load. The H plus is buffered, but an anion is excreted with the sodium when the ability of kidney to replace sodium with H plus is exceeded. Vasopressin antagonists, ADH antagonists inhibit the action of ADH on the kidney tubules. For the regulation of volume, composition, and osmolality of the body fluid, uh, they're closely associated with the control of water and electrolyte balance of the body, as body water content reflects volume of the body fluid compartments and concentration of electrolytes influence composition and osmolality of the body fluids. And kidney plays a very important role in the regulation of extracellular fluid volume. ECF volume is primarily dependent on sodium homeostasis, which contributes significantly to the regulation of plasma osmolality. So, thus, control of volume, composition, and osmolality is a major function of kidney that is interdependent physiological phenomena. How sodium composition concentration is controlled in ECF. The major ionic constituents of ECF are sodium and chloride. These two ions contribute considerably to the ECF volume and therefore they determine the plasma volume. And kidneys play important role in regulation of ECF and plasma volumes by controlling transfer of sodium and chloride between the tubular fluid and interstitial fluid. The volume sensors in JJ apparatus generate appropriate signals in response to changes in the ECV that influence the GFR, and then the renal excretion of sodium chloride and water. Neural mechanisms, stimulation of the renal sympathetic nerve in response to activation of the volume receptors leads to decrease in sodium chloride excretion by three mechanisms, that is by reduction of GFR. Sympathetically induced vasoconstriction of afferent arterioles decreases the GFR. Increased sodium reabsorption occurs because of the sympathetic stimulation directly increases the reabsorption of the sodium from the proximal tubule. Increased renin occurs because of the sympathetic stimulation, uh, which are produced from the JJ cells that in turn activate RAS, which in turn promotes the formation of the angiotensin 2 and aldosterone. Both these hormones increase reabsorption of the sodium and chloride from the renal tubule. Hormonal mechanisms like uh, controlling sodium chloride concentration are mainly three, that is renin angiotensin aldosterone axis, atrial natriuretic peptide, and antidiuretic hormone. Regulation in different conditions of ECF. Regulation of sodium excretion in euvolemia. During euvolemia, that is normal blood volume, sodium excretion is adjusted by reabsorption of sodium chloride in the tubule. Aldosterone is the primary regulator of sodium reabsorption in the body, in the kidney. Till the kidneys are normal, the aldosterone secretion is normal, and the level of dietary intake, uh, any level of dietary intake of sodium chloride is adjusted to maintain the normal blood volume. Regulation of sodium excretion in hypervolemia. Volume expansion initiates the responses that increase sodium excretion from the kidney. These mechanisms decrease absorption of the sodium chloride from the kidney and therefore decrease ECF volume. By decreased renal sympathetic activity, by decreasing the activity of the renin angiotensin aldosterone system, and increasing the ANP secretion. In hypovolemia, uh, as it occurs because of the excessive sweating, vomiting, diarrhea, uh, which decreases the volume, which is detected by the low pressure volume sensors that initiate the following responses. So there will be increased renal sympathetic discharge, there will be activation of renin angiotensin aldosterone system, and it causes decreased ANP secretion. Okay, so these are disorders of fluid volume and electrolytes. Uh, the fluid volume disorders like disturbance of fluid volume results in either dehydration or overhydration. However, based on the osmolality of the body fluid, they are categorized into six varieties: isoosmotic dehydration, hypoosmotic dehydration, hyperosmotic dehydration, or isoosmotic volume expansion, hypoosmotic volume expansion, and hyperosmotic volume expansion. Electrolyte disorders of sodium balance. Majority of the body's sodium is in ECF, and it is the most abundant cation in ECF. Total body sodium is the main determinant of ECF volume. Regulation of sodium by kidney is important for maintaining sodium balance in the body. The normal range of sodium in ECF is around 136 to 145 milliequivalents per liter. Hyponatremia is defined as the condition in which the plasma concentration of sodium is less than 135 milliequivalents per liter. Mild hyponatremia is between 130 to 134, moderate 120 to 129. Severe hyponatremia when sodium levels falls less than 122 milliequivalents per liter. There are different types of hyponatremia based on the clinical history and the volume status, divided into three categories: hypovolemic type 1, euvolemic type 2, AB, and hypervolemic, that is type 3. Causes for hypovolemic type 1, the renal causes are the renal loss and excess of diuretics, mineralocorticoid deficiency as it occurs in Addison's disease, salt losing deficiency, osmotic diuresis, cerebral salt wasting syndrome, and bicarbonaturia with renal tubular acidosis and metabolic alkalosis. And extrarenal causes where the usual sodium is less than 20 milliequivalents per liter are diarrhea, vomiting, third space loss, burns, pancreatitis, and trauma. The second type is euvolumic, that is type 2A and type 2B. The primary causes are polydipsia, decreased solid intake, that is beer, potomania, uh, inappropriate secretion of ADH hormones, that is excessive secretion of ADH hormone, glucocorticoid deficiency, hypothyroidism, and the drugs. And the hypervolumic type 3 causes are nephrotic syndrome, cirrhosis, cardiac failure, and acute chronic failure. Hypernatremia is synonymous with the primary water depletion. So this is defined as a condition when plasma sodium concentration is more than 145 milliequivalents per liter. Some of the external renal causes are mainly the GI loss, osmotic diarrhea, like which occurs in viral gastroenteritis, malabsorption, and lactulose infusion. And other causes are secretory diarrhea, as it occurs in cholera, vipoma, and carcinoid syndrome. Disorders of uh, potassium balance, it is a major intracellular cation. Normal level is being 3.5 to 5.5 milliequivalents per liter. Hypokalemia is when the plasma levels fall less than 3.5 milliequivalents, and this condition is called as hypokalemia. The causes are decreased intake, starvation or clay ingestion, maybe redistribution of the potassium into the cell, and increased loss uh, by any means will lead to hypokalemia. Hyperkalemia is a condition where the potassium levels increases more than 5 milliequivalents per liter. The major causes for hyperkalemia are renal failure, decreased potassium secretion, enhanced chloride reabsorption, shift of potassium out of the cell, and the tissue breakdown. Okay, so these are the things which are going to cause hyperkalemia. Okay, and this is all about the regulation of the the different ions, water, and volume by the our kidney. Thank you.